So good evening, doctor. I, Shuman, on behalf of Shield Healthcare, welcoming you all in today's webinar. And the topic of today's webinar is freedom from infertility, a methodological approach by Dr. Kaberi Banerjee, madam. And before moving into the webinar, let's have a look on our Shield Connect page. This is our Shield Connect page, that is knowledge sharing platform. And here you can find different blogs written by many eminent doctors across India. And these are the past webinars already we have conducted in many topics in our platform by many doctors across the country. And this is the PCOS awareness blog. Here you find different articles related to the PCOS only, and it is available in the different regional language as well. And this is the most important COVID-19 awareness blog. Here you can find articles related to the COVID-19, and the most important thing is our key opinion leaders. Almost 250 to 300 doctors are currently supporting us this knowledge sharing platform. And now it's time to start the webinar, and it's my honor to introduce ma'am, although madam doesn't need any kind of introduction. I'm just briefing a bit. Madam did her MBBS from AIIMS New Delhi and MD in Obstetrics and Gynecology from AIIMS New Delhi. Madam did her Diplomat of National Board in Obstetrics and Gynecology from National Board of Examination, New Delhi. Madam did her MRCOG from Royal College of Obstetrics and Gynecologists, London, and FRCOG from Royal College of Obstetrics and Gynecologists, London. Madam is currently associated as a medical director, Advanced Fertility and Gynecology Center, and Madam is the member of many eminent bodies, a member of Royal College of Obstetrics and Gynecologists, London, member of National Academy of Medical Sciences, MNAMS, India, member of the Association of Obstetrician and Gynecologists of Delhi, member of the Federation of Obstetrics and Gynecology Society of India, FOXY, and Madam is also the member of Indian Society of Perinatology and Reproductive Biology, and National Association for Reproductive and Child Health of India, and she's a member of AIISO-NIS, the AIIMS alma mater. Apart from that, Madam has many awards and credits to her credit, and out of that, President's Prize for Poster presented at the Japan Society of Obstetrics and Gynecology Commonwealth Scholarship in 2004-05 by St. Thomas Hospital, London, for training in assisted conception, IVF ICSI. IMAMS Distinguished Service Award in IVF 2007, Bharat Jyoti Award for Outstanding Contribution in Medicine in 2008, IMA NatCon Best Clinician Award 2015, Mail Today Health Conclave Excellent Award 2015, World's Greatest Brand in IVF Dubai May 2017, Process Reviewer Prince Price Waterhouse Private Limited. When was the Economic Times Excellence in Healthcare Award 2019, ISAR Champion Award 2019, and Best State Chapter ISAR Award 2019, and many more. Apart from that, in academic terms, Madam has many research papers in national and international peer-reviewed journal as well. With this short introduction, I request Madam to take over the session, and meanwhile, I request all the participants for their active participation, and please post your queries on the QA dashboard of the Shield Connect page. So once the webinar will so thank you, Madam, and over to you.
Thank you very much for the kind introduction. I thank Shield Healthcare for giving me this opportunity, and Mr. Balaji for making it happen today. And today we are going to talk about a methodical approach from freedom of infertility. Now, we all know that complete freedom may not be possible, but if we work methodically, right from our history taking, examination, investigations, then our results may be very good. And if we miss even small things, then our results will not be good. So in this 40 minutes to 1 hour's duration, I'm going to touch upon very basic points, but these will kind of translate into how it will improve our results. So let's proceed. Next slide. So in infertility, like in other fields, the right diagnosis at the right time and the right intervention is very, very important. Next, please. Suman, you can mute your mic, please. Next. So the demography, the full name, the religion, the address is very, very important. Now, The religion is important in the sense that sometimes when we need third party reproduction, it may not be culturally acceptable. So we must keep that in our mind at the time of counseling. Address is very important. Does the patient stay close by? Do they live far away? Do they come from a different town? Do they come from a different country? Now, many times we have seen that a person who has come from a different country is wholly solely come for the infertility treatment. So they are available the whole time, the whole day, in fact, for the treatment. But any couple who is in the city and is working, their time constraints have to be taken into consideration. Age, we know, is one most important critical factor, and the age decides what treatment we offer because it can lead to lower egg reserve, chromosomal defects, and increased miscarriage rate as the lady's age advances. Next. Therefore, in advanced stage, rather than waiting too long, we must directly offer advanced ART options like IVF and in some cases donor eggs. Next, please. Now, while we are taking the history of the occupation, what kind of job does the woman do? Is she a homemaker or is she on her laptop 8 to 10 hours a day? Now, that kind of will give an aspect of whether she needs more intensive activity to lose her weight, to become more active, and small tips like getting up after 20 minutes of work or in between yoga, pranayam, stretching may make a long difference in the overall outcome. Again, as I had mentioned, you cannot just say, okay, you need IVF and you need to come here from 20 kilometers distance, stay here, wait in the long waiting queue, even for one ultrasound scan. In today's world, you have to be patient friendly to keep the patient consistent with the treatment. So, what is her schedule? What are her stress levels? Because a high busy schedule can affect on everything. It can affect on whether we need to freeze the embryos this time, transfer later on. How do we schedule her visits? For example, for some patients, we even give the injections to them and teach them, do an injection teach video. They take the injections with them, the 5 6 days they take it, and then come to our clinic from the 6th to 7th day. Then, is there anything that is affecting her ovarian reserve? Next, please. We all know that smoking adversely affects the ovarian reserve. So, this pointed question, especially in the metropolitan cities, must be taken, and women must be advised to give up smoking and change the lifestyle parameters to the best of their ability. Next, please. Marital history, very, very important. Just asking how long are you married, 4 years, is not. There's a whole lot of deep history inside. How long have they been married? How much trial have they given? Are they living close together? Next, please. What is the sexual history? Has the marriage been consummated? What is the frequency of intercourse? And do they know the fertile period? If you go into the detail, you will sometimes find out that the couple have not even cohabited. And this, if you don't give them time and do a checklist properly, you will miss completely. In a busy OPD with 10 people around them, nobody's going to tell you that, doctor, we've not had sex in this marriage. You have to give them that time, that respect, so that they come out with these sensitive matters. Then, how frequently are they having the intercourse? We all know if it is once per week, it's about 17% chances. If it is thrice per week, it is 50% in 6 months. So that is a big factor. Do they know when the fertile period is? Though most of it is available in the internet these days, still you will be surprised with some couples who have absolutely no knowledge of when the fertile period is, how long the egg stays in the body, how long the sperm stay. All this you need to give that extra 5 minutes to the couple. Next, please. Now, this is a very important, 2 by 2 table, age and duration of trying. If the age is less than 35 years and she's trying for less than 1 year, and we are assuming the egg reserve is good, we can still take it easy. If the 35 years, we can make it 32, 33. But if the age is more than 35 years and they have been trying for more than 1 year, then really, wasting more time, that 1 year you can extend it to 2 years. So if the duration of trying is high, the age is high, then wasting time on another cycle of ovulation induction, follicle monitoring, and all that is just going to reduce the couple's chances of overall conception. But yes, in a younger couple, you can still give time. Now we all know that the menstrual history is usually taken in a fraction of a second, but that menstrual history can give us the entire diagnosis of type 1, type 2, type 3 ovulation disturbances. For example, if it is a hypogonadotrophic hypogonadism or a hypergonadotrophic hypogonadism, she may not have attained her menarche, or even if she has attained, it would have, stopped after some time, and that we have to differentiate it from the type 2, which is the PCOS. Next, please. So the menstrual history, when was her last period, will help us differentiate into the various ovulatory categories and whether it is irregular, early cycles, delayed cycles, will help us pick up points of fibroid, polyp, low ovarian reserve, polycystic ovaries, and hence guide us as to whether we need any surgery or we need ovulation induction or we need to counsel regarding gonadotrophic stimulation, so we get an idea right at the beginning as to what kind of patient we are dealing with. Next, please. So again, dwelling into a little bit deep into it, how are they? Are they heavy? Are they scanty? Do you have pain during your periods? Again, the whole spectrum of fibroid, polycystic ovaries, endometriosis comes in front of our eyes, and we have already started our differential diagnosis at the back of our minds. Next, please. Obstetric history. She's come with infertility, but she could be secondary infertility. She may not be telling you the history of a past MTP if you're not giving her enough space and enough privacy. So, you know that these points, sometimes you may have to separate the man and the woman to take certain more history. If you don't give them the time, it's not going to come out. She may have had an MTP in her early lives, and then that may have led to an Asherman's. So all these things, were there recurrent miscarriages? Was there sepsis during her first childbirth? Did she conceive easily? Was there ovulation induction given during that pregnancy? So again, a complete approach to her obstetric history is very important. Past medical history. Now, especially in the metropolitan cities, and I'm sure all over the country, we are seeing an epidemic of obesity, diabetes, hypertension, advanced age group, and with it comes all these illnesses, and therefore that makes the ART treatment as well as the pregnancy quite at a high risk. So, not to say that we cannot offer treatment. If the recent fertility sterility edition has given lot of papers on obesity, and they have said that of course, getting the ideal BMI is the best thing, but will you wait forever to get the ideal BMI and lose the age opportunity? So no, they have said that if the patient is of the age, say plus 34, 35, and she is obese, please do not wait unnecessarily, and please do offer her ART treatment. But of course, lifestyle, directions must be given. The hypertension, the diabetes, the heart disease. So you must have your fertility clinic, fertility center must work in tandem with a good medicine specialist, with a good endocrinologist to give the best outcome to your patient. Similarly, was there some episode of infection in the past? And did she take tuberculosis treatment in the past? Do we need to do a laparoscopy, or do we need to, look deeper into the endometrium, say in a non-medicated cycle, to see how the endometrium is before we start the treatment? So all these quick questions must be taken. Okay, was there a diagnostic laparoscopy in the past? If so, why was it done? What were the findings? What is the chromotubation status? Did she have a sterilization? Is this her, she may have, there are some women who have been unfortunate, some childhood mishap of one of the children. They have come again for another child. So they will have tubal sterilization. What kind of sterilization? When was it done? What was her age? What is the duration? Is there any surgery of previous laparotomy? What was the incision? What was the indication? Was it a fan and steel? Was it a vertical scar? And did she receive treatment before she came to you? What were the ovulation induction cycles? Was it clomiphene citrate? Was it letrozole? Did she have an IUI? And especially if they've had IUI, please do ask, how was the procedure? Was it easy? Was it a lot of pain? So these will, especially if you're thinking about IVF, these will guide you towards the transfer process. Today, like Saturday is one of our busy OPDs, and IVF cycles are increasing all over the country. And most IVF centers would see patients coming to them with previous IVF cycles, multiple failures. So you need to study that IVF, the previous IVF cycle also in depth. What were those? What eggs were used? Self, donor, what protocol was ICSI done? What was the grading? What was the endometrial? So it is a whole protocol and a methodical approach for every point in the patient's history. So these points will help us decide, do we leave the patient for a while, just give some guidance, just give some medicines, or do we decide for an advanced ART or a third party reproduction? What protocol should we use? Should it be a fresh cycle? Should it be a frozen? Day 3, day 5? Do we need some procedure before we go ahead with the IVF? By now, your mind has already made a checklist kind of a thing. So please do not forget that some illnesses have a genetic predisposition, and do ask history of early menopause and carcinoma in the family. Now we have taken a good history. We have spent about 10-15 minutes with that. We have made our differential diagnosis. We kind of know what we are going to expect in this patient. Now we come to the examination. Now in the examination, of course, the general physical examination, her BMI is all very important for us to guide. If it is a young patient, less duration, overweight, PCO, please focus on lifestyle and weight loss. And nowadays, there are specific guidelines, of course, your myoinositol, your metformin, your exercise for at least 30 to 50 minutes in a day or alternate day with lot of cardio. So all these are specific guidelines. So these are called the SMART guidelines, specific, measurable, achievable reproductive targets. Those have to be given. Lose weight and come back to me. The patient is going to say, oh, so just tell them, this is your diet chart. You can go plus minus this way, walk for 30 minutes, do a cardio for this time, this, come back to me in 2 weeks, and let's see how you're doing. So this way. Next. Of course, we cannot forget the thyroid, any, hyperandrogenic features in the skin, the tanner staging of the breast, the galactoria, if there is any, axillary and pubic distribution in hypogonadrophic hypogonadism, we must examine. Next, please. Per abdomen, this is my favorite because many times we are in the rush, we've taken a history, we've done everything, and we suddenly just put the TBS to kind of see the uterus and the adnexa. But no, please look at the abdomen, and you can look at the fibroid, which can be touching up to the umbilicus, a very bad scar, which will give you an idea whether you should do the laparoscopy again or not. Very important. Next, please. Now, sometimes these patients, especially those with failed cycles, you should ask specifically that when you have a period and then you have a period in between these two periods, is there watery discharge, And if they say yes, then you are strongly suspecting hydrosalpinx. So put in a speculum always. And the other advantage of that is if you don't do it, then, on the embryo transfer day, you may be struggling, you may be encounter a bad cervix. So all those things should be ruled out. A cervix which is high up, which is difficult to cannulate, may need transfer under maybe some sedation or anesthesia, or preparation. So a per speculum examination is very important. Similarly, a local examination to see, especially in cases of fibroid endometriosis and deep endometrioma, where it's a fixed pelvis, gives you an idea as to what to expect if we are planning a surgery, if you're planning an egg pickup, etc. Then we have the blood tests and the radiological investigations. And our aim is to, if there is an ovulatory disturbance, our aim is to differentiate which one it is. And we can easily do it by the FSH, the estradiol levels, and the AMH levels. Usually, we will have a low FSH in hypogonadotrophic, a normal FSH in polycystic ovary, and a high FSH in a hypergonadotrophic. And we must not forget the thyroid plays a critical role in pregnancy rate. Maintain it to 2.5 MIU per ml and have strict TSH control. Maintain the prolactin. Cabergoline is the drug of choice. Yes. After the endocrinological investigations, we would like to move to the radiological assessment, which is the key part of your diagnosis and future planning. Things like antral follicle count, endometriosis, hydrosalpinx, intrauterine pathology must be ruled out before any procedure is contemplated. Sometimes, when you are suspecting an intrauterine anomaly or multiple fibroids, a 3D ultrasound, and I prefer an MRI for fibroid. It gives fantastic mapping of the fibroid, lets us know which type of fibroid it is, and whether we need to go through a laparoscopy or a hysteroscopic approach. So, all these planning is very important. Now, regarding the tubal assessment in young patients without any pelvic discomfort, pelvic pathology in the past, or history of PID in the past, a radiological investigation of hysterosalpingography or sonosalpingography is enough. But in older patients with associated anomalies like endometriosis, PCOS, or there is history of PID, laparoscopy may be the better way to evaluate the tubes. So, when there is long-standing infertility, when there is associated anomalies, when you are suspecting tubal block, when there are uterine factors, please do not hesitate to put in the scope, and this will give you a lot of information and you can treat many conditions side by side. An endometrial biopsy is indicated where there is irregular cycles, thick endometrium, ruling tuberculosis, previous failure, and scratching. Though it is not in the realms of today's discussion, tuberculosis and scratching are both two debatable topics, and there are opinions for and against it, which I think is beyond the preview of today's discussion. So we have formed this opinion and we have done certain procedures like ovarian drilling, cystectomy. Yes, I think we've missed a slide. Can you go back, please? Yeah, cystectomy. Next, please. A myomectomy and a tubal clipping. Following all this, so all this information has come through right from her age, what work she does, how long she's been trying, what is her menstrual, obstetric, past history, her examination findings, her ultrasound findings, hormonal evaluation. Next. And this, what is the implication of all this evaluation? If it is a young couple, we can modify lifestyle. We can give them, the fertile period when it is. We can guide them towards consummation of marriage. We can guide them towards a better lifestyle and weight loss. Sometimes there are certain medications, for example, testosterone in a man, which is not good for the sperms. We can stop those medications. We can add DHEA and antioxidants for low egg reserve. We can add antibiotics where we are suspecting PID and tuberculosis. We can give medical treatment for younger groups. We can add certain surgical treatment to increase our chances of success. We need to choose the correct ART, IUI, IVF, ICSI, third party, which one. Whether we need to add certain add-ons like immune treatment, etc., depending on previous history. So all this gives us the idea. Can we go back to the previous slide, please? As to what we need to plan for this particular lady. Now, once this is done, and if you go ahead, you have optimized the outcome in the lady by your methodical approach. Now, let us go to the male factor. Just catch a glass of water. Give me a second. Male factor, as we all know, is 50% of the infertility causes. And though the female age, egg is very, very important, the male factor, most people say, you do the ICSI, you overcome it. But you can't be offering ICSI to everybody. If you do some tweaking and treatment with the male factor, especially in the younger group and duration of infertility is less, you can get magical results. So again, age in women more than 35, the egg quality goes down, and in men more than 45, the sperm quality does go down. Not so dramatically, it's dramatic after 65, but definitely the recent papers have shown that male age is also plays an important role in success rate. Next. Again, what kind of work are they doing? Can we reduce their obesity levels? Are they working in a chemical factory? Can we give them some guidance regarding that? There was a man with oligospermia. Then finally, on probing, he said, I work in this chemical factory. And I said, then, yeah, what are the supports that you get when you're working in that factory? So these questions, can you go to a different department, the admin department? So all those things. Again, the sexual history in the man needs some, you have to be empathetic to the couple. What is the frequency? Is there any erectile dysfunction? Is there any ejaculatory dysfunction? You need to talk to them about it. Are you smoking, taking alcohol, any drug addiction, any medication? So many of these, after spending 5-10 minutes, when you hear them out, they will come out with their problem. So you see, if it's a 35-year-old lady and a 38-year-old man married for 2 years, trying all the fertile period vis-a-vis same couple who have not even consummated or having erectile or eject, the treatment is going to be entirely different. The prognosis is going to be entirely different. So you need to take these questions into account. Past medical history. So if there is any sperm issues, was there orchitis? Did they have any injury? Are they taking any medications? Is there history of sexually transmitted diseases? Was there any surgery done? Was there a hernia repair? Was there history of testicular biopsy or FNAC? How much does he weigh? Is he obese? Is he fit? Is obesity in the way of regular intercourse? Is there gynecomastia? Is there hypo is there hyperestrogenism and low testosterone effects in the body? Local examination, the size, consistency, epididymis, varicocele, prostate, seminal vesicles. Semen analysis can be divided into sometimes specialized tests, post-ejaculatory urine analysis, followed with endocrine, ultrasound, and genetic screening. As we all know, we are still following the 2010 WHO. Apparently, the recent guidelines may be out soon, but still 15 million concentration per ml, 40% motility, and 4% morphology is the cutoff. Now, in the semen analysis, viscosity, sometimes next, complete lack of coagulation may be agenesis of seminal vesicles. Failure to liquefy may be poor prostate activity. Color may be yellowish in longer abstinence, reddish in infection. Low volume can be because of retrograde ejaculation, infection. High volume can be because of medications and increased prostatic activity. So you see these 2, 3 small points, but if you just glance at semen analysis and miss all this, you have missed infection, you've missed abstinence period, you've missed certain genetic problem, you've missed retrograde ejaculation. So focus on the finer points. And is there azoospermia, zero count, or is there oligospermia? As you know, azoospermia can be because of hormonal, ductal problem, and oligospermia can again be because of ductal problem, endocrinopathies, infections, or idiopathic. Asthenospermia, when the activity or the progress is not as good as it should be. It could be because of long abstinence, some metabolic deficiency, or genetic disorders. Necrospermia is they are not active, they are not alive, they are dead sperms. Could be because of infections and varicocele. Teratospermia, morphological disturbances, can be because of excessive smoking, toxin exposure, varicocele. Pus cells in the sperm can be because of genital tract infection or inflammation. So, So as you see that in that whole you have to go point by point to see whether you are picking up anything in the semen analysis or not. Just count motility, morphology, no. See everything in detail. Absence of fructose can be because of, in the sperm can be because of lack of seminal vesicle or obstructed vas. Next please. Now, this is something, the patients will give you the history that after the ejaculation, the sperm volume is very less, and when they urinate, there is milky urine. Now, for them, there is a very good chance of pregnancy. So, you have to alkalinize them for 1 or 2 days, take the urine sample, centrifuge it, take the sperms, and do IUI or IVF with ICSI. So, this small history taking is important. Sperm function tests are used to detect abnormalities. There can be sperm survival, transport, and problem in different steps of fertilization. Now, there are the most important Added sperm function test is the DNA fragmentation and sometimes the host test, osmotic test for viability, dead or active alive sperms. Though most international guidelines do not give much importance to all these extra sperm tests, they do not change the treatment of the patient, but they have suggested that they give us some idea regarding the counseling and prognosis of this patient. Now, DNA fragmentation index is a test which measures the damaged DNA in the sperm. Less than 15% indicates good fertility potential, and when DNA fragmentation is more than 25, ART is indicated, and more than 30%, that ART should be ICSI. DNA fragmentation can be because of environmental issues, advanced paternal age, occupation, or lifestyle. So what can you do? You can avoid the factors that are promoting the oxidative stress, or you can take oral antioxidant treatment. You can treat underlying pathology like varicocele or genital tract, and you can offer ART treatment when there is excessive DNA fragmentation. Endocrinal evaluation is also important, and that will give us the treatment whether we need to give certain medications. When do we do endocrinological evaluations in male factor? When the concentration is less than 10 million, when there is erectile dysfunction, when the volume is low, and when there is signs and symptoms of other endocrinopathies. So for example, you have measured the testosterone and estradiol in the sperm, and if they are normal, you may not need any medical treatment. But if the testosterone is less than 300 nanogram and the testosterone estrogen ratio is less than 10, aromatase inhibitor may be the treatment of choice. If the testosterone estrogen ratio is less than 10 and testosterone is more than 300, again aromatase inhibitor. But when the TE ratio is more than 10, you may give HCG. So this is a concept that is coming up, which comes into the hormonal and medical treatment of male factor with oligoasthenozoospermia. So ultrasound can also be done, and the ductal evaluation, and this the urologist friend will come to rescue whether there is a seminal vesicle or ejaculatory duct problem, congenital or acquired, enlarged seminal vesicles, or CBAVT. Sometimes it is not possible to always palpate the local genital in the OPD, and ultrasonography comes to the rescue, which gives us the testicular volume. It gives us the presence of varicocele. It gives us the presence of other cysts and spermatoceles, etc. So this can we go back, please? So ultrasound is very important in male factor infertility, though most of this information can be gained by local examination also. Next. Now, when do we do a genetic testing? When do we advise karyotype? In men with less than 10 million sperm count, again a repeated less than 10 million. It's usually some papers say less than 5 million. When there is non-obstructive azoospermia, you will always do karyotype. And when there is history of recurrent miscarriage. Now this I can never forget. There was this couple who had severe oligospermia. Every time I would do an IVF ICSI and an embryo transfer, the couple would get pregnant. But either it would be a biochemical, twice it was biochemical, third time it was an ectopic, and then they were lost for follow-up. Then they came back after 6 to 8 months, and then they said they visited another doctor and the doctor suggested karyotype. And I said, oh yes, it really skipped my mind and I should have advised it to you. And then came the Robertsonian translocation. And at that time, the PGS, PGD was not so common in the country. They were an affording couple. They went to London, they got the IVF with PGD done, and they have a healthy baby now. So these are the few things that we must keep in the back of our mind. Next, please. Next, please. So, chromosomal abnormalities can also detect Klinefelter, excess Y syndrome, inversions and balance translocations, like I have mentioned. Next, please. Then, Y chromosome microdeletion in case of azoospermia. Next, please. In that, if you have microdeletion in the C region, there is a severe oligozoospermia, but it may produce sufficient number of sperms for ICSI, but in A and B, there is very poor result. Now, very important, obtaining the ejaculatory sperm sample. Now, during your history taking, see, you have done all this and you are doing your IVF, you've taken out the eggs, and suddenly, your junior comes and tells you, ma'am, the husband cannot give the sample. Now, what? You'll freeze the eggs, you'll do a testicular TESA and all. But why? Why wasn't this question addressed before? Did we ask the male, are you comfortable giving the sample here? If not, can you bring it from home? And if they bring from home, please get it signed that this is our sample and we take responsibility for it. And could we have frozen the sample earlier? And also, it is important to note, and more studies are coming up, that in severe oligoasthenozoospermia, suppose taken the first sample, dead sperms, less motility, take an immediate sample, and the second ejaculate has better sperms and better ICSI results are coming with that. Explain the various, you don't need microtessa for every patient, where your testicular volume is good, where your hormones are good. You may, and if you have the epididymis that is palpable, then you need a percutaneous epididymis sperm aspiration. But in those cases where failed tessa, small testicular volume, relatively raised FSH levels, next please, microtessa will be the answer. Next please. So if there is a previous failed cycle due to male factor, you need to ask a few questions. How was the sperm collected? Was it a fresh sperm or a frozen sperm? What was its quality? Was the DNA checked? Was there a genetic testing done? Was double ejaculate taken? Was it a testicular sperm? So you see, as in the female, in the male, in young men, modify their lifestyle. Ask them to get active. Stop the drugs. Stop the smoking. Change your medications. Take the antioxidants, antibiotic treatment, hormonal supplementation, surgical treatment in cases of ejaculatory duct obstruction, the right surgical sperm retrieval technique, followed by the right ART technique and PGS if required. Do they need donor sperm? And always, if it is culturally acceptable, take the consent. If the patient is willing or they cannot afford higher forms of ART, if they've had multiple failed attempts with their own sperm, this discussion must take place. So in our center, we have, various ways in which we try to inculcate all these points in a methodical approach. Please hold on. Let's go back to the previous one. Yeah. Next. So these are history taking points. And then is the investigation list. Next, please. Where we are, can we go back to the previous one? Yeah, so in this you would see we have covered the hormones, we have covered infection screening, we are ensuring that there's rubella IgG positive, thalassemia, nowadays COVID, PCR, semen analysis, everything. Next. In the male factor, we are covering their hormonals in azoospermia, in severe oligoasthenozoospermia. The various factors need to be covered. If it's there is a methodical checklist, You will not forget. This is when the patient is going to the lab. You have made a huge plan, a beautiful plan, but on the day of egg pickup with, work going on in the center, you need to conglomerate it in a place. So we have a patient summary list just on the day of egg pickup. What is their blood group? Was viral screening done? What kind of sperm are we using? How many follicles are we expecting? Any other added point is also added in this. Next, please. This is our lab sheet where, we are going to add the number of follicles, number of eggs, number of M2s, number of PNs, day 2, day 3, day 5, status of the embryos, and also embryo transfer, how did it go, etc. So that when everything is in your sheets, we hope it comes a positive test. But if at all it is negative, which can happen, then you have it all documented and you can relook and revisit and try to have a refined plan. So that is all for today. I hope we have covered certain important points for you, and I'll be happy to take some questions if there are any.
Yeah, thank you very much, ma'am, for this nice presentation. Almost you have covered all these things related to the infertility approach. Thank you very much once again. So, ma'am, just give me 1 minute to collect the questions. So, if you allow me, then, ma'am, we can discuss on that.
Yeah, for 5-10 minutes we can.
Yes, ma'am. Yes, ma'am. Just 5 minutes. So, ma'am, as we understood that in case of infertility in female factors, many parameters are associated with it in terms of PCOS also, and it's related to the PCOS. So, if a patient comes with PCOS, so will you directly what will be your treatment approach on that? Will you decrease the PCOS problem and then go for the infertility treatment, or first you want to explore the infertility as well?
See, it depends on the PCOS patient can come at various stages in her life. For example, it's a young PCOS who is just married and who is not keen on fertility at the moment. Number two could be a PCOS who has had numerous failed ovulation induction cycles. And number three could be a PCOS who had whose fertile chapter is over, and yet she's worried about her PCOS symptom. So in the first, and so you have to be very direct, is what have you come to me for? Do you want treatment for your PCOS or do you want treatment for your infertility? And if they say we don't want treatment for our infertility at the moment, and if you think that's a challenge, for example, advanced stage, 4 5 years they've been trying, you have to give them the guidance that, well, okay, we can treat your PCOS, but it is time that you also at the side by side get your PCOS, your fertility checked. So let us just stick to the first patient, say a young patient who's just about started trying, who's getting irregular cycles, and is a case of PCOS. This lady is purely on lifestyle and certain additions in her, like multivitamins, antioxidants, myo-inositol, metformin, weight loss, exercise. And if she's still not getting her fertile regular cycles, I would not put her on oral contraceptive or cycle regulators if she's trying to conceive. But if she's not trying to conceive, I can still put her on that. But most women, I do not. Lifestyle and metformin and myo-inositol is what I give young patients.
Thank you, ma'am. And another question is, ma'am, maybe recent research is coming related to the DHEA treatment for a long time or so. So that can sometimes causing some problem. So what is the actual means ideal period of treatment with DHEA?
See, DHEA treatment, you have to rule out that there should be no bleeding problems, there should be no liver disorders, and there should be no long-standing acne problems. If these three are ruled out, then you can give DHEA for a reasonably long period, say 3 months, And you must always evaluate the patient either, on the phone, or they can come for a visit or an online chat, as to ask them how their symptoms are they getting any acne or any other side effect. As soon as the acne side effects are coming up, DHA must be tapered down. And also, I am sure all our, my friends here know, strangely, DHA is only when your AMH is low, when your egg reserve is low. It is not a treatment for PCOS, and which I'm sure everybody knows.
Yes,
I have
obviously.
found prescriptions with metformin, myoinositol, and DHA to my utter surprise. So that should not be given.
And ma'am, another question is, in case of varicocele, if you found a patient with varicocele, so is there any medical management is there, or the surgical surgery is the only option for the varicocele, or in terms of some improvement in the pain or some other related issue related to varicocele, is there any medical management is available?
See, varicocele, it is a two perspective. One is presence of varicocele without any sperm problems, nothing needs to be done. But sperm problems like oligoasthenoteratozoospermia with a varicocele, then you have to see what kind of varicocele. Is it a mild varicocele or a moderate to severe varicocele? So nowadays the studies are very clear that moderate to severe varicocele with OATS, oligoasthenoteratozoospermia, need surgical treatment for better improvement of sperm. But if we add the antioxidants along with it, lycopene, carnitol, coenzyme Q, and all that, that also may improve. The literature is still plus minus on this, but there is still some data which is saying that it does improve the overall sperm parameters.
Okay, ma'am. So thank you, ma'am. I couldn't find any other question right now. So if you allow me, then we can conclude this session.
Yes, definitely. Thank you once again. And
So thank you very much, ma'am.
Thank you,
Yes, sir. Thank you
madam.
very much, ma'am, once again for your valuable time in our platform. And in future also, we will look forward for some valuable session from. So thank you, madam, once again.
Thank you, madam. Thanks a lot. Thanks for your
thank
time.